Now, beyond that, there's common sense. So I'm going to describe to you a study that a hypothetical study that I use to convey this to colleagues and patients. Think of you're studying musculoskeletal injury in high schools across the country in two groups that you're going to contrast. One is sedentary gamers, the other happens to be athletes. Now, which group will the study find is having more higher levels, higher numbers of musculoskeletal injuries? Which group?
Obviously, the athletes.
Yeah. Now, are the athletes having more injuries because they have more unhealthy ligament, cartilage, tendon, muscle, bone?
No, I wouldn't
No,
think so
no. Why are they having it?
because they are doing more high risk activities and they're more physically active.
Absolutely. Seems common sense, doesn't it?
Mm-hmm.
Now it's interesting. I also did a little study of my own when this came out, and I looked at it and analyzed it quickly, and then sent in an editorial about what I thought was going on. I didn't tell anybody at first, and so I would ask the men coming in, and I would tell them, "Wow, there's a study. You may have seen it, and it showed increased fracture in the older men on testosterone, not the hypogonadal men that were on placebo. What do you think of that?" Every single one of them says because they're doing more. They're out there doing more, just like me. Like when I started treat, and so I would suggest some of this is common sense, and it's unfortunate. Again, I think it's an unfortunate consequence of not having clinicians more directly involved routinely in the design of these kinds of studies and the analysis of the data that comes out of them. But that's why even from the beginning. Not that I didn't think there was a relationship, but I didn't think the relationship between the increased injury had anything to do with a negative effect on those tissues.